I'm George Woolreich. I'm the President and Chief Executive Officer of the College of Physicians of Philadelphia. I am by training a psychiatrist and a psychoanalyst. The question of whether burnout, depression, and suicide is a new phenomenon within the medical community often comes up. The phenomenon have existed always, but perhaps because of some of the changes in training and in lifestyle, they have become exacerbated. Working inordinate numbers of hours without adequate rest, without adequate support, are not conducive to good health, good mental health. The prevalence of physician suicide is grossly underappreciated. It is one of the most underreported forms of death in this country. I think the best way to increase awareness about the issues is to talk about them, to be willing to call a spade, and being willing to do something about it. I remember as a child, the word cancer was rarely used in polite company. I think one of the reasons that we've had such great advances in cancer research has been that people have been willing to talk about it and therefore willing to seek ways of dealing with it. Mental health, along with obesity, are two aspects of health which, in a sense, don't get much respect. And until I think we see mental health as part of our being human, we will be less likely to deal with it. In the past year and a half, the College of Physicians of Philadelphia and the 7 area medical schools have become aware of the increasing aspects of depression, burnout, and suicide in medical students, in recent trainees, and have come together to form the Delaware Valley Medical Student Wellness Collaborative. The collaborative is seeking to raise awareness of these issues and to better foster the possibility that most of these issues can be dealt with in a constructive and ameliorative way.
Hi, everyone. Welcome to the final grand rounds for the season. We are addressing the silent public health epidemic, suicide, and the workforce. I'm Kristen Rexing. I'm an assistant professor at LaSalle University in the Department of Urban Public Health and Nutrition, and we are very excited that you could join us for this very important topic. We encourage you to use the chat feature to communicate with each other or with the panelists. We also have a question and answer box that you're able to submit questions to that we'll get to at the end. And if you are tweeting or using social media, you can use the hashtag #PhillyGrandRounds. So the Philadelphia Public Health Grand Rounds, our purpose is to address important public health issues in the Philadelphia region. We bring together local speakers from multiple disciplines and perspectives to help generate new ideas and form collaborations to really strengthen public health within the community. I'd like to thank our co-sponsors, the College of Philadelphia and the Philadelphia Department of Public Health, and acknowledge the Independence Foundation. Again, following the grand rounds, we'll have a Q&A session, so please feel free to submit any questions as they come up while you're listening to our presenters. There'll be an evaluation form at the end, and if you would like to support the section, we highly encourage you to become a member. We've got great events all throughout the year. Thank you to all of our institutional supporters. And I will introduce our moderator, Dr. Matthew Herford. He is the president and CEO of the Community Care Behavioral Health. Thank you, Dr. Herford.
Thank you very much, Kristen, and thank you all for being with us this evening. This is an incredibly important topic after what has been really a historical year, obviously, in terms of health challenges. We have, in modern history, never asked more of our healthcare workforce than we have in this past year. And yet, within this pandemic of COVID-19, there is increasingly an epidemic related to behavioral health and to suicide. And healthcare workers, physicians, nurses, therapists, case managers, and other allied health professionals are in no way exempt from this. And as we will hear and learn they are in fact at increased risk, sometimes twice the rate of others. Hundreds of physicians die each year by suicide, and many, many more across the healthcare field. The reasons, of course, are myriad. As Dr. Woolreich said in the opening video, issues related to burnout, caregiver fatigue, and then barriers associated to seeking care, including guilt, shame, drives of perfectionism and expectations of heroism in healthcare, oftentimes present barriers and challenges to people seeking care. Demoralization and despair can follow. And as a result, we see increasing rates of various behavioral health challenges, substance use disorders, and tragically suicide. You know, the proverb, physician, heal thyself, from the Gospel of Luke, and much later Aesop's fable of the frog and the fox are often cited as examples of and warnings against hypocrisy and quackery. But there are other messages within both of those, including, I think, the perhaps unintended message that if we as healers are unable to address our own problems or heal, that we are somehow not worthy of that title. And that, I think, in effect, exacerbates and challenges all of us in the field to both identify in ourselves and each other the warning signs associated with suicide. We look across healthcare and we don't apply this standard elsewhere. We don't often expect surgeons to perform appendectomies on themselves, nor do we expect an ophthalmologist to remove his or her own cataracts. We rely on the skills and expertise of others to help us. We trust in their care and their abilities to help us heal. Suicide and mental health conditions, behavioral and substance use disorders, emotional stressors that can contribute to suicide are too often exempted from this standard and this approach. As a psychiatrist myself and as the CEO of a behavioral health organization whose primary task is to ensure that there is an adequate network of high-functioning, caring behavioral health professionals to support 1 million Medicaid beneficiaries across Pennsylvania, we think a great deal about the health of our workforce and wonder who will heal the healers. We're very fortunate today that our esteemed panel of experts will help us answer that question by educating us about the scope and contours of the challenge and help us identify what we can do to help eradicate suicide and inoculate ourselves against future outbreaks. For it will take a public health approach to address this public health crisis. Fortunately, this past year, we've learned a great deal about mobilizing around a public health challenge. And the interventions that we have used in the field of medicine and in healthcare and as a society to help address the COVID-19 pandemic, well, they have behavioral health analogs for the epidemic of suicide. Just as we tested for COVID-19, we can implement screening measures to help identify people that are at risk for suicide. While we had social distancing to prevent this transmission of this virus, we should be promoting social connectedness, which we know helps to eliminate the possibility and risk of suicide and other behavioral health conditions. We've relied on PPE, personal protective equipment, to protect our healthcare workers. In behavioral health, we have personal protective exercises, good sleep hygiene, health behaviors like not misusing drugs or alcohol, and physical exercise that we know are protective for mental health and can reduce the risk of suicide. And finally, if indicated, we have evidence-based treatments, medications, therapies, and other modalities that can help treat someone in the healthcare workforce who's having these conditions, who's thinking or contemplating suicide, and connecting to them connecting them to those modalities is of the utmost importance. So the challenges are great, but the opportunities are many, and we have learned a tremendous amount over this past year. Our goal today is to understand better what the risks and contours are of the suicide epidemic impacting the healthcare workforce, And it is my pleasure and my honor to introduce two of Philadelphia's most influential public behavioral health leaders who will be kicking us off. Dr. Jill Bowen, the Commissioner for the Department of Behavioral Health and Intellectual Disability Services, and Dr. Sosamolu Shuyenka, who is the Chief Medical Officer, also with the DBH-IDS. I'll turn it over to Dr. Bowen, who will start our presentation.
Thank you. Thank you, Matt. Hello to everybody. Welcome. Very excited to be here on this very important topic and to discuss with everybody today some of what we have learned and what we know and what we've been doing at DBH-IDS. So first, let me take a moment just to introduce those who are not as familiar with the Department of Behavioral Health and Intellectual Disability Services in Philadelphia. We are the city's behavioral health and intellectual disability agency. As such, we are part of the administration, and we oversee a network of nearly 200 providers across the full continuum of care of services for behavioral health and intellectual disability. And our mission is to educate, strengthen, and serve individuals and communities so that all Philadelphians can thrive. Our vision, we envision a Philadelphia where every individual can achieve health, well-being, and self-determination. And our values, you can see right there. So this is a tall order. These are high expectations, and we work to achieve them on a day-by-day basis. There we go. Okay, we do this work by utilizing a strategic plan to prioritize to address our changing environment or pace. And we do this through these 5 focus areas: prevention, early intervention, which further develop services around community needs; through treatment and services, where we increase access to our services; through health economics, where we improve processes and practices to enhance cost effectiveness; through infrastructure and intelligence, where we increase the use of business analytics and information flow to inform service delivery and improve outcomes; and perhaps most importantly, through innovation, where we innovate to improve programs and services. So there's an innumerable number of projects that are connected to these 5 priority areas, and our staff are deeply engaged in these areas. So this is an awesome responsibility and a tremendous amount of work for the staff. And we do this by organizing into 7 different divisions to make it a bit more manageable, just through administration, finance, and quality, through planning and innovation, through the behavioral health and justice division, through the behavioral health division that includes mental health and substance use disorders, through the chief medical officer's division, through the intellectual disability services, and through community behavioral health, which is Philadelphia's managed care organization for those eligible for Medicaid. The vision that really pulls all of this together in terms of moving collective needles forward and system change and system improvement is what we call TECH. The TECH vision addresses trauma, achieving equity, and engaging community. It layers on top of our strategic plan of PACE, and it provides that lens through which we can focus our transformation initiatives. So as you can see from what I've been discussing, this is a lot of responsibility, rather intensive work, high expectations. And so the importance of making a commitment to the workforce is essential. Prioritizing the well-being of the workforce, providing these opportunities to practice the kinds of activities we know are helpful, such as stress reduction, healthy social connections, acknowledging the traumatic nature of suicide crisis line work, public behavioral work in general, and its impact on the staff, and equipping staff and supervisors to continually be aware of signs and symptoms of vicarious trauma. We have initiated for the whole city a program called Boost Your Mood. You can see it behind me as my backdrop, and you can go to dbhids.org/boost. And there you will see 6 different areas where folks can easily click on for wellness tips. There's a section for numbers to know and places to go, for coping with COVID-19, for children, youth, and families, for community support, and addressing trauma and violence. And we've been intentional about informing our workforce as well as the community as a whole that it is there for everyone. So our workplace wellness philosophy works around these 5 different areas. And you really need to address all of them to improve the health and well-being, quality of life for workforce. And so they include, I'll go from the left around, but occupational. So that's where we have workplace diversity, equity, and inclusion programming, training and development, robust learning management system, and a vibrant leadership and mentoring program. For mental health focus is addressing stress and the traumatic nature of work, the pandemic for sure, racial injustice, violence in the community. We have clearly been impacted by multiple layers of trauma and need to address the stress associated with them and promote resilience. In the emotional realm, we've got mindfulness training, guided meditation, virtual healing spaces, and of course, the Employee Assistance Program. And in the social, the Quality of Life Committee, virtual lunch hours, internal Facebook pages, and physical virtual exercise classes, working clubs, and nutritional support. So some of the efforts to help our folks during the pandemic included moving forward together open forum sessions around the election outcome. And more recently, vaccine listening sessions and vaccine anxiety sessions. There are healing spaces and listening sessions that are associated with the trial in the killing of George Floyd and the retriggering of anxiety and community violence as a whole. And folks really provide feedback that these are invaluable. We've also tried to combine social and physical with virtual walks that help folks be able to maintain connectedness during the pandemic as well as their physical health. And we made a successful transition to work from home. We checked several times while people were working exclusively from home to see how they were doing, to see what tips they had for each other, and to see what they felt they still needed in order to be able to be successful while working at home. And some of those included setting work from home norms with the team, setting limits on when work begins and ends, identifying clear communication channels for urgent matters, and establishing standard hours for phone calls and the appropriate hours to send emails. And so that feedback loop was incredibly helpful. So during this particularly difficult time when we had our routines disrupted and isolation that came with our necessary responses to the pandemic, we needed to stay in as much touch as we possibly could and to try to work to address the issues that our workforce was experiencing. And in point of fact, they were incredibly productive, innovative, and effective, which does not mean that they were not experiencing depression, anxiety, and stresses related to isolation and the routine disruptions. So I am now going to turn this over to my colleague, Dr. Shuyinka, who is going to work through some of the more specifics around suicide in Philadelphia. Thank you.
Thank you, Commissioner Bowen, and it's a pleasure to be here with you all. And so I should start by, I will start by saying that any suicide is one too many. Any suicide is one too many, and we recognize that. And so I'll be providing an overview of suicide, the data within the city of Philadelphia, and we'll be looking at some of the efforts that the city is making to address this issue. I will lead in with a caveat that this data does not include Philadelphia's residents who died by suicide outside Philadelphia, nor does it include non-Philadelphia residents who died within the city boundaries, within the county. Also, that 2020 data is preliminary at this point. These are raw numbers over the past 5 years. So we see that the number of individuals who died by suicide over the last year, 2020, as far as we know at this point, were 167, and that represented an increase over 2019. Better look at those numbers is the mortality rate, which again was increased over 2019. I do want to point out that Philadelphia's mortality rate, suicide mortality rates were 4 points less than the national average and 5 points less than the average across the Commonwealth of Pennsylvania, which does not mean in any shape or form that this is, we're taking this lightly within the department. This is a breakdown by the numbers, so we can see that consistent with the literature, the greatest number of deaths are in the individuals aged 25 to 64, and whites still comprise the largest ethnic group that experiences suicide, death by suicide, followed by Blacks. We also know that more males die by suicide in the city of Philadelphia, in the county, than females. And to some extent, that's a reflection, we know from the literature, of the method of suicide completion. Hangings and firearms still comprise the greatest percentage, with firearms slightly more than hangings. Death by poisonings of drugs are also common. As other speakers have said today, COVID pandemic really was I would say, gigantic global stressor for everybody. And so right from the beginning, there was a concern about deaths of despair. Actually, that term had been coined preceding COVID. And with the stressor, additional stressors, all the stressors that came along with COVID, it was reported in mid-2020, about 3 months into the pandemic, that about 40% of adults were experiencing suicidal thoughts, and 11% were considering suicide seriously. Now, unfortunately, our data here in Philadelphia does not lend itself to this type of specificity that would let us know what their professions were, or and so on. But we do know from syndromic surveillance data that's collected by the PDPH that people present, and that data really is gathered from individuals presenting to emergency departments throughout the county with suicidal or suicide-related events. So if we look at this box over here on the right, shows that the numbers were fairly consistent with previous years. If we look across the last 4 years, with a slight dip about June and an uptick later in the year about December. And I'll go a little quicker now to stay within our time. This is a busy slide, but it shows the percentage change in the call volume for our crisis center, the Philadelphia Crisis Line, which, as we can see, is made up of 3 lines: the National Suicide Prevention, the National Suicidal Lifeline, the Suicide Line, which is a local line, 686-4420, and the Delegate Line, which is typically used to process involuntary commitments and other calls, 685-6040. And we can see that right around the beginning of the pandemic, between March and about June, there was a significant drop in the volume of calls across all lines, which at the end, when we tallied up all the calls across the 12 months of 2020, resulted in a dip in call volume overall of between 7 to 10%. Now, Dr. Bowen mentioned that the department has a real commitment to wellness, which obviously wellness across the entire population, which obviously includes a commitment to ending suicide. And the framework for that is the Zero Suicide Model, which is a total commitment to eliminating suicide. And this operates within the framework of 7 different tasks. It's to lead, train, identify, engage, treat, transition, and improve. And so our strategy is built around this idea. Now, the Philadelphia Suicide Prevention Task Force is sponsored and coordinated by the department as an entity to achieve that vision of 0 suicides within Philadelphia through collaboration, engaging stakeholders, and using a coordinated approach. This group is a large group, over 30 individuals, that draws from all groups, researchers, people with lived experience, and so on. And we collaborate with other groups in the state. This is a slide that, and I'll wrap up. I'll begin to wrap up now. This is a slide that lists out additional initiatives within DBHIDS, training and education. A lot of work has gone into elevating and underscoring the importance of suicide prevention all year long, but with a particular focus during the month of September. Behavioral health screenings, which are available through the Healthy Minds Philly website. DBHIDS has also sponsored and continues to support survivor loss groups, the Network of Neighbors, which supports communities that experience traumatic events. And these are a few future events, future initiatives, training and education. And the big one that I would say is likely will be a game changer for the entire healthcare community across the country is the 988 implementation that's scheduled for July 2022. We continue to ramp up and refine our data collection and syndromic surveillance, continue to work through our suicide prevention coordinator, Hunter Robbins, works closely on engaging the community, and we continue to work with on wellness within our own teams. And I will transition now to Dr. Massoud. Thank you very much.
Thank you, Dr. Sriyanka, Dr. Bowen. Our next panelist, as Dr. Sriyanka mentioned, is Dr. Mona Massoud, who is the chief organizer and founder of Physician Support Line, a national grassroots initiative for supporting physicians navigating the COVID-19 epidemic and beyond. Dr. Massoud.
Thank you so much. Hi, everyone. I'm a Philadelphia area outpatient psychiatrist. I trained at Temple University Hospital. I'm from North Carolina, but I am very proud to have kind of adopted Philadelphia as my home. I am the founder and chief organizer of Physician Support Line, and my presentation will be a little bit different from my colleagues here who presented today. I will be taking you through a story of lessons learned through the work in Physician Support Line. We are a grassroots initiative that was created from a completely, if not me, then who kind of attitude, which I think a lot of us can relate with, is how we felt at the beginning of this pandemic, where it felt like there was no guidelines, no playbook on how we were supposed to handle something like COVID-19, and especially as being in the healthcare workers, and especially with the expectation of being the quote unquote front lines of this war. And in those feelings, those very helpless feelings, came the birth of Physician Support Line. And just if you guys are interested to check out our work, read more about who we are and the, our mission and our work and everything like that. And if some of you are psychiatrists and would like to volunteer your time, you can find all that information on physiciansupportline.com. I will also include the number in the chat later for you guys to save on your phones in case you yourself may like some support, or if you would like to share with others. This is our infographic. We are a free, confidential peer support line. We are run by now over 800 volunteer psychiatrists nationwide. That we started off as being a support line for our medical student and physician colleagues navigating the COVID-19 pandemic, but have since become a more sustainable resource that covers any subject. You can call us about any topic. It doesn't have to be a crisis. And it's really there to kind of lend a safe space to discuss the many intersections of our personal and professional lives. We are available 7 days a week due to the generous time and expertise of our psychiatrist volunteers from 8 a.m. to 1 a.m. Eastern Standard Time. Please check us out. We have Physician Support Line on Facebook as well as Physician Line on Twitter. So who we are a national grassroots movement. How this all started is I'm a moderator of a COVID-19 physicians group, and it was formed at the beginning of the pandemic in order to, tease out the misinformation from the real information that was coming in from us to us from all corners of the globe of real time in terms of how to identify, how to treat, how to diagnose, how to deal with COVID-19 in the hospital settings. And we were sharing all this information across social media platforms, specifically Facebook, and a private physicians group made up of over 30,000 physicians. And as I was moderating these posts for their content and legitimacy, I would start seeing other posts filter in, such as anybody else having insomnia, anybody else leaving the house in the morning thinking might be the day they get COVID. Is anybody else writing their wills? Who are the good lawyers to write your wills for my family in case I die? Taking care of people with this virus. And all of these things started coming in. And as a psychiatrist, this was a writing on the wall. These are the risk factors we start looking for when we're predicting an impending mental health crisis. And I knew I myself was finding myself not able to sleep at night. And on a whim, one day, I just wrote as a moderator to this group, I wrote, calling all psychiatrists, who's with me in supporting our physician colleagues as we navigate the COVID-19 pandemic. I didn't know what was going to happen from it. And the response was incredible, which validated that my fellow psychiatrists were seeing what I was seeing, that it wasn't about if we're going to have a mental health crisis, it was about when. And it was not as if we didn't have risk factors before. It was understanding that now was the time to act, or we were going to see risk factors turn into catastrophes. And so I often get this question, why is this only for physicians? And how about other healthcare workers? Are we not stressed? Is this not relevant for us as well? And what I want to touch on is that centering any particular group when it comes to mental health does not diminish that other groups are not suffering. It is an intentional focus for physicians because, as we may have heard at the beginning of this talk today, that physicians have an increased high risk of suicide due to not only the culture, the social stigma of medicine, of suicide, but also the internal stigma within the culture of medicine about the failures as a physician, and the need for physicians to be somehow superhuman and have all the answers and be able to be the ones doing the healing and not needing to be healed. And all of this kind of stigma that accumulates over time gets translated into an incredible high risk for feeling trapped and for feeling like there are no options and for making suicide seem like a viable option. And so by intentionally focusing on physicians and acknowledging that there are 300 to 400 physician suicides a year, that is one physician death by suicide a day. By acknowledging that, by centering it, by being unapologetic about normalizing and acknowledging that statistic, that allows for there to be discussion about this crisis. So I will say, with our healthcare worker colleagues, even though Physician Support Line was specifically geared towards physicians and is for physicians, if a healthcare worker colleagues or a non-healthcare worker colleague calls a Physician Support Line, we do have prompts to be able to direct you to similar resources meant for frontline support. So what are we offering? If a physician calls the support line, we are offering anonymity, which is incredibly important. Again, I will talk about not only individual issues, but we will hear soon about systemic reasons on why physicians really value anonymity. So there will be no fear of reporting or professional repercussions. It feels like the stakes are very high for us to have gotten to this point, maybe past training, to the point that we are paying off student loans, that we are still in debt, and we are still, in this double bind, that the medical licensures, of hospital credentialing, all of these things that could all of a sudden get rid of everything that we feel like we have worked for or worked towards. It is a real fear that us approaching any other, within system support is going to be have some repercussion. So also what we offer is a trained psychiatrist and a physician colleague, which is important because there's that shared experience in peer support work that allows a person to feel safe in their vulnerability, because they automatically and implicitly know that of the journey of medicine, the difficulties, the joys, all of the different intricacies of medicine that you do not have to explain or validate your need for support. We have live psychological crisis intervention using de-escalation and other types of techniques as well. We also have a lot of resources if you go to physiciansupportline.com of things like workshops, therapists. If you want to do continuity of care, we are partnering with therapyaid.org, which is offers low cost or pro bono therapy for frontline workers, and also psychiatrists that you can establish pro bono or low service costs continuity of care for you to, for your wellness. We have applications, articles, videos, further reading, all of that. We also have a protocol for safety of self if it is applicable. What we do not offer is recommendations on medication or supplements, a doctor-patient relationship, a therapist-client relationship, or psychiatric consultation on your patients. We have policies and procedures that have been vetted and written by our pro bono legal services at Cozen O'Connor. We are covered under the CARES Act and the Good Samaritan Healthcare Workers Act to do this work. We have a standardization in our protocol and in our approach to if a suicide call does come in. For volunteers, if you're interested in volunteering, we do not require malpractice coverage, but we do require active state licensing in order to standardize our volunteers. We use a HIPAA compliant cloud-based phone system. None of our volunteers, physicians here, receive phone numbers of who's calling. It's all anonymous as well. So the caller will call the hotline number and they will dial the number prompt to be directly connected and immediately with a volunteer psychiatrist. On our end, we will log into this smartphone app that will allow the anonymity and confidentiality to occur. Our volunteers shift 1 hour each, so that's why having so many volunteers is very helpful. 8 a.m. to 1 a.m. Eastern Standard Time. And now we are above 800 volunteers. Like I said before, you are not required to disclose any identifying information. You don't have to tell us your name. You don't have to tell us anything about you. We are there to work through any sort of immediate stressor on a subject, to discuss resources, to discuss de-escalation techniques. There's no time limit, no appointments. You can talk to us about any subject, and you can call multiple times, but you cannot request a specific psychiatrist. Okay, I'm just going to skip through this for a second. We have supported over 2,000, I believe it's around 2,000 physician callers since the onset. We spend about average of 20 to 60 minutes per call. We collaborated with many physician organizations such as American Medical Women's Association, the APA, the American Medical Students Association, Vibrant Emotional Health, which is owners and operators of National Suicide Prevention Lifeline. We are now going to be partnering with them on making Physician Support Line part of that network. And we have been recommended all the way from the CDC to NIH, and we are a recommended resource amongst most known entities. So we are going to now be collaborators with Vibrant Emotional Health. We continue to do ongoing education, mental health advocacy initiatives. And like this and like many other topics and conversations I have with medical schools, medical education, graduate medical education, hospital systems and organizations. And most proudly, I want to conclude on this, is that we are working on a systemic issue, which is what leads to physicians not seeking help, which is fearing the risk of licensure and being revoked their privileges to practice medicine after spending so much emotional, financial, and personal energy into cultivating this, cultivating their profession. And the project's name is Human Before Heroes, and we're partnering with Dr. Lorna Breen Heroes Foundation, which you will be hearing from shortly, and American Medical Women's Association on changing the mental health disclosure on state medical licensing applications in order to encourage and normalize mental health seeking amongst physicians. So the lessons learned is that most of our calls start with an apology, which apology for using the service that was intended for the caller. And it just tells you about the societal, cultural expectations and the internal expectations we have of being physicians, that somehow we have to apologize when we are not well, as if somehow we are not human beings that suffer as well, like our patients do. And so much of our work on the support line is just normalizing that normalizing and calling attention to how we view ourselves and the unfairness of how we view ourselves. And that we are able to, that one of the reasons for for physicians reaching out is that they do not feel that they can trust their institutions to keep, with their mental health, and also they can't trust their institutions to not be punitive about seeking mental health care. And that in itself is the biggest reason for why the support line even exists. That there is punitive outcomes for physicians seeking help. And it really highlighted for us the need for systemic reform, which we will be hearing about soon. This is the steering committee, kind of in our early days. You guys can contact me at Dr. Mona Massoud at physiciansupportline.com. You can follow us on Twitter. You can follow me, I'm shrink wrapping. And on Instagram, you can visit us on physiciansupportline.com and Google Humans Before Heroes and read about our initiative to change medical licensing applications. Please spread the word. Here we are, Physician Support Line. I will write our number and our hours in the chat box for you, for those who want to save it. Thank you so much for having me.
Thank you very much, Dr. Massoud. Our next panelist is Dr. Matthew Winterstein, who's the Director of Research in the Division of Child and Adolescent Psychiatry at Thomas Jefferson University. And he is also the President of the Delaware Valley Medical Student Wellness Collaborative. Dr. Winterstein.
Great, thank you, Dr. Herford. It's very exciting here to be with all of you tonight, and looking forward to continuing this discussion here. My task is really to talk a little bit about campus mental health and suicide prevention, and thinking initially, I'm going to be looking at this more of a broad scope and thinking about colleges as a whole. We'll kind of get ourselves into the healthcare professionals and thinking about students within that population too. But there's a group amongst all of this when we talk about colleges that are frequently missed, and that's the key focus here is going to be on looking at our staff, our faculty and staff, and how we can better support them as we move forward. Oops. There we go. So here's just some data. The bottom line with all of this is that as the past 5 or 10 years have shown us, more and more individuals get onto college campuses who have experiences with mental health. They've either attended counseling in the past, they've been prescribed and taken medications in the past, they have a history of suicide attempts. As you can see here, over 10% of suicide attempts being made, slightly more for females than for males. And of those that have made suicide attempts, almost 25% of them have happened in the past year. This is a higher risk population than what we have typically seen on college campuses in the past. And they are coming in, though, with histories of getting support, which is a unique thing because it then, the help-seeking barrier that's often there sometimes gets broken down a little bit better. When we look at some previous reports of data back in 2015, what you find is that there was an increase in counseling center utilization that had gone up 30 to 40%, but the increase in enrollment across college campuses was only up 5%. This is not necessarily an issue of more students seeking long-term care on college campuses, but rather an increase in the number of people who need immediate short-term crisis stabilization, utilization through their college counseling services. And so we've sort of moved away from the model, many colleges have moved away from the model of, you can go and seek support from somebody and sometimes you can get connected to a counselor for the entire length of your stay in college. Most colleges have moved away from a model like that and are really looking at more short-term programming and referring people out or into other mechanisms to do follow-up care after that. The rapid access to service, again, going up significantly over the last few years. We know that for college students, the rates of suicide vary a little bit, but about 7 to 8 suicides per 100,000 students. It's actually quite protective to be in college because compared to non-college students within the same age cohort, you find that the rates are actually a little bit higher than that. We know that young adults between the ages of 18 and 25 more likely to consider suicide in the past year than those older. And suicide is the second leading cause of death on American college campuses. So there's a number of challenges, though, that are associated with this when we think about how do we help students. First, it's dealing with this issue of autonomy versus student safety. Up until this point, they've lived at home, their parents, their other caregivers have supported them along the way through all of the steps of seeking support, getting what they need. They walk onto a college campus, they get stressed out with the work that they're doing, and we expect them at that point in time to start asking for help and taking care of themselves. How do we do that in the context of realizing there are students out there that need our support, they're never going to ask, but Do we let them ask? Do we push it? How do we make those things work? There's a disconnect with family and home supports. They've been supported in that environment before. They come to college, they think I can take care of myself. I can do this on my own. I don't need the other support, and oftentimes get into bad habits that prevent them then from going back and receiving that support that they've had in the past. We talked about the independent help seeking issue. When we think about just suicide prevention on college campuses, there's often a real lack of direction in terms of how we address these issues, which results then in a very narrow focus. That focus then falls almost exclusively on counseling centers across college campuses. And the interesting thing, after speaking with lots and lots of people on many, many college campuses across the country, what you find is there's no college out there that's going to say, we're not interested in suicide prevention. All of them will say, this is a priority for us. We want to make sure our students are happy and healthy and that they're doing well here. But the dedicated resources that follow supporting students in that environment often go down dramatically. And then the flip side of this, actually related to it, is counseling center staff training when it comes to working with individuals that are suicidal is variable at best. And in fact, many of them don't have necessary specific evidence-based treatments that they're able to do with college students because they haven't been trained in that area. The good news, though, is the data actually suggests that they do a very good job of treating students for anxiety, depression, and a few other occurrences. So the JED Foundation started, I can't remember exactly what year it was, but about 15 years ago, the JED Foundation started as a mechanism to work alongside colleges and those in that environment to support people who may be at increased risk for suicide. They came up with this strategic plan, comprehensive approach, and you can see that there's these 7 different facets that are related to suicide prevention. I'm not going to go into every single one of them, but as you kind of walk your way through the circle, what you see is that all of these things do a good job of targeting the important facets, not just mental health, but all of the things that are related, sometimes indirectly, but more directly to it as well. So looking at social connectedness, Matt Herford talked about that at the beginning, and sort of being connected to other people. That's an important piece. Identifying people at risk, increasing the help-seeking behavior, providing mental health and substance use services, following crisis management procedures. And then we look at restricting access to lethal means. We look at developing life skills. It's a great model. There's a huge piece of the model that's missing, and it's not the JED Foundation alone that's responsible for this. There's lots and lots of college campuses that apply these models and think about how can we do this, and they ignore, not intentionally, but we often ignore the faculty, the staff, and kind of the roles that they have. So what are some of the challenges that we see with our college faculty and staff? The first has to do with roles and responsibilities. If you think about this, who taught them to teach? How many college professors actually went through a course on how to be, or more than a course, multiple courses on how to be effective teachers? And most of them have come to their institutions, unless it's a liberal arts school where they did in fact go there to teach. Most of them came to their institutions to do something other than teaching, but teaching is one of those elements that they do. And if they can buy their way out of it, they will buy their way out of it. It doesn't mean they don't enjoy it. It doesn't mean it's not something that becomes a part of who they are and the roles that they have there. But they are often there for research. They're there to run programs. And in healthcare environments, they're there to do clinical work. Yes, they train people along the way, but they're there for other purposes. And so the priority, or the lack thereof, around teaching can be problematic sometimes. Faculty are expected to support the students. Again, we think about how can we support them in some capacity? How do we identify students who are at risk? You go back to that model. How do we do those kinds of things? The problem, of course, is that forces faculty often to take on this impression of being well. How can we help other people if we can't even help ourselves? And so if we think about it from that perspective, it creates this sense that we need to be perfectly capable of taking care of ourselves, projecting that out there into the world that we're okay. If you're struggling, it's fine. Come talk to me. I can handle it. I'll take it on. So all of these things that go into that kind of aspect of it. Mental health efforts we know on college campuses almost exclusively directed at students, and the one thing and very few others that exist for faculty are EAPs. But beyond that, where's the support that they have? Then we have what we like to call, what are the pandemic problems? if you've taught a class during the last year, you know that it looks a little bit like, this webinar that we're doing here tonight. You're talking to a bunch of faceless, disengaged, and sometimes absent people in an audience. I know college students who get on, they log on, they go to sleep. They're in class, but they are not in class. It is hard to engage people. And again, without that training on how to engage people within a virtual platform, people are lost. What's my role? Does it even matter? Do people care that we're doing this kind of stuff? There's research and publication challenges that have gone on during this pandemic. Research projects have stopped. Research projects have slowed down. Participants aren't coming in. Publication, I don't know about those of you out there and where you're publishing these days, but if you publish something or you submitted a manuscript that had COVID in the title, you were fast-tracked into getting published. If you were publishing fantastic work that had nothing to do with COVID, it's getting pushed further and further and further back. So how do I meet my university's expectations for the work that I'm supposed to do if I'm not doing something this year on COVID specific? Working from home isn't always what it's cracked up to be. Everyone says, oh, it'd be great. You don't have the commute, all this other kind of stuff. It is not that simple. There's a whole host of family stress that not only exists for the faculty member, but they're taking on the family stress that exists in their home environment. Their kids are doing school in the room next to where they're doing telehealth or where they're teaching a class. Their spouse maybe lost their job. How do we manage all of those kinds of things and expect to just kind of go on with our day and do the work that we're doing? Job security was an issue for some folks, and really thinking about, can I continue to do the work that I was doing the way that I was doing in a way that I'm going to continue to be protected here? And then, of course, let's not forget about those working in healthcare and the monumental task of managing, doing the work that had to be done and it continues to be done since the beginning of this pandemic, taking care of yourself, trying to take care of everybody else in the midst of all those kinds of things, and supporting your family and finding a way to keep everybody safe. What are some solutions to it? We need to expand our models of prevention to include faculty and staff. We can't simply expect college campuses to say the students are our priority. Yes, they give us money, fine, but we need to support the people that are supporting them. There has to be an approach that looks at it from that perspective. We need to expand support services to faculty and staff. At Jefferson, one of the things that we did is we started this sign out support program. And so in essence, people could on demand come into rooms where somebody from the counseling center or somebody with a clinical background in the behavioral health field was there and available to talk about what was that experience like on that shift? How did that play out for you? What are you dealing with? And the conversations that happened through that were incredible in terms of just thinking about, I can't go home, I'm staying in a hotel, and kind of managing those. We have to expand support services to faculty and staff so that they benefit in the same way that some of our students do. We need to include faculty and staff in some of the parallel processes with student support. So things like QPR training, mental health first aid training, lots of trainings that we do to support our students. The reality of it is when we get trained in those areas, we also learn how to identify those risks in our colleagues, those risks sometimes even within ourselves, and say, wait a minute, maybe this isn't something that everybody else experiences. Maybe I do need to talk to somebody. So there's a parallel process that we can engage people in. Story slams, a thing that we did through the Delaware Valley Medical Student Wellness Collaborative. We have people come and share their stories and their experiences and their vulnerabilities into these kinds of things. And that is so important in destigmatizing mental health. Mike Weinstein is on here. He'll be part of our Q&A later. I think many of you probably have read his article and the story of what he's been through and his experience. To have individuals like him come forward and talk about that helps to destigmatize the issues around mental health and suicide prevention amongst people, certainly within healthcare in his particular settings. But there's been, I think Penn does something called Festival of Failures. Jefferson has this Failing Forward project. The idea is to teach people how to succeed amongst the challenges that we have that we are dealing with. The Delaware Valley Medical Student Wellness Collaborative is something that in the video that George was talking about before. We encourage you to get on there to see the kind of work that we're doing. It's really focused on improving student wellness and well-being, but engaging faculty through that process as we go through. I'm also involved in a higher education suicide prevention coalition, the HESPC. You can go on our website and learn more about those kinds of issues. We have a conference every year, including one coming up in just over a month, where we have colleges and individuals who represent students and college life coming all from all over the country. It's virtual, of course, this year, so you're welcome to pop on there as well. And thank you very much. I appreciate your time.
Thank you very much, Dr. Winterstein. And I'd like to introduce our final panelist for the evening, Mr. Corey Feist, who is the co-founder of the Dr. Lorna Breen's Hero Foundation, and also the CEO of the University of Virginia's Physicians Group. Mr. Feist.
Thank you for having me. I know that I stand between you and your evening, and so I intentionally didn't have cocktails. I didn't have cocktails at all before this. I didn't have slides because I wanted to talk about this issue from the perspective of both the professional and kind of personal way that this has impacted my life. So as a career healthcare administrator, lawyer turned physician group executive, for the last few years, we have been working at the University of Virginia Health System on this topic of burnout and the topic of addressing the root causes of burnout for our healthcare workforce, looking at ways that we can improve the electronic medical record efficiency and really try to return the joy back into the practice of medicine. Last year, on April 26th, my professional and my personal world collided when my sister-in-law, Dr. Lorna Breen, died by suicide. She was here in Charlottesville, Virginia with the family, and I'm here today to tell you a little bit about the work that we have done in response to really a collective cry for help that we have heard from the industry since we shared Lorna's story shortly after she passed away. A little bit about our foundation first. We are a tax-exempt 501c3 nonprofit foundation. It was co-founded by my wife Jennifer and I. We are both lawyers by training, and she comes from a family of physicians, and her mother, who is a nurse, so very familiar with healthcare in our and trying to address the issues associated with burnout. And really trying to focus first and foremost as a foundation, reducing the burnout of healthcare professionals and safeguarding their overall well-being and job satisfaction. Our vision is that obtaining mental health support is universally viewed as a strength and a job prerequisite for healthcare professionals. I think we're pretty far from that right now, so we've got a long way to go, but we're making progress. Tell you a little bit about Lorna. Like many of you, her life aspiration was to be a doctor. In fact, for Lorna, even though she didn't grow up in New York, actually she grew up in Pennsylvania. Her dad was a trauma surgeon at Geisinger. Lorna always wanted to be an emergency room physician in New York. And she was living that dream, having spent a career at New York Presbyterian Hospital, serving as the medical director of the Allen emergency room at the Allen Hospital since 2008. But her entire childhood and everything that she did to prepare herself for this career was really, with the goal in mind of being a New York City emergency room physician. And she was a pretty well seasoned one by the time the pandemic hit, having started her career in the early 2000s, having trained at Long Island Jewish Hospital. Lorna died by suicide, as I said, on April 26, 2020. And you may have seen this in the national news. In a period of 3 weeks, Lorna went from treating COVID patients to contracting COVID herself, and then returning to an emergency room, which by her description was like Armageddon. She was completely overwhelmed, as were all of the physicians and staff. with a truly relentless number of sick and dying patients, many dying in the waiting rooms without enough oxygen in their portable oxygen tanks to keep them alive until they could be seen. And like a good soldier, Lorna and her colleagues worked around the clock during the peak of the pandemic in New York, with limited PPE, insufficient supplies, scarce oxygen, and not enough beds and not enough help. And overly worked and really despondent, she became really unable to move. She had no prior history of depression or anxiety, but this moment was just simply too much. And rather than worrying about her own mental status and to take care of herself, she started immediately worrying about her job. She worried and feared that her colleagues might notice that she wasn't able to keep up. So she just kept going. One day before she died, obviously, she called my wife, a physician. They were talking every day, and she said, "I can't get out of my chair." And this was never something that you would have heard from someone like Lorna, really the toughest of the tough. And so because the New York was closed down, my wife, Jennifer, put together probably the most rapid help chain of friends and family to get her out of New York. And we got her from a friend car chain down I-95 where my wife, Jennifer, was driving up north from Charlottesville, and met her on the side of the road on 695. She was almost incapable of answering the most simple questions like, do you want McDonald's or Burger King? Are you hungry? Do you need to stop for a bathroom break? She couldn't do it. So Jennifer took her to the emergency room at the University of Virginia, where she was admitted to the psych unit, where she spent many days until she came home, and then in a moment took her life. But before that, she expressed to us, now that she had received formal mental health treatment, concerns about her job again, concerns that she was going to lose her license now and would never be able to work again. We thought that was an impossible and implausible kind of a scenario, statement that was coming out of her. After she died, however, and after the news broke by national media less than 12 hours after she died, we became flooded and overwhelmed by this collective cry for help from physicians across the country and across the world who were saying that they too were suffering in silence. They were part of, as Dr. Massoud said, the 400 physicians each year, or not yet, but quickly becoming part of the 400 physicians a year that died by suicide. And so, understanding we could never get Lorna back, Jennifer and I decided to lean into this problem, and lean in, we certainly have. I won't go more through, you've heard plenty of details this evening about statistics, and you don't need to hear more statistics from me, but I do want to point something out that we haven't yet talked about, but I'm observing across the country through my work, which is that in addition to the impact that this is taking on the mental health and physical health of the workforce, it's also impacting patient care. There is a 200% increase in medical errors when the healthcare workforce is burnt out. And as we've seen, almost a doubling of the amount of burnout in our healthcare workforce to date, we have now seen a commensurate level of, or a rise, not really a commensurate level, but a rise in healthcare medical errors across the country, particularly bedside errors. And I'm working with the Virginia Hospital Healthcare Association on a focused project around connecting the mental health of the healthcare workforce, of the mental health of the healthcare workforce with medical errors and quality. This is the next quality conversation that we're having as a country. So a really important aspect of this work, which just is so basic, if you might think about it. Of course, if your workforce is not working at their best, they will be incapable of doing their job at their best. So as I mentioned, after the New York Times published the article on Lorna, and then we decided to go on the Today Show about 48 hours after Lorna died, we received this overwhelming call and cry for help from the industry. And that evolved into areas of focus for our foundation. And those have been really three areas. I'm going to give you a little bit of a thumbnail about what we've been doing. So first and foremost, we've been building awareness on the mental health prevalence of that exists in healthcare to really reduce stigma. So awareness, number one. Number two, we have raised money to fund research and programs that seek to help to reduce healthcare professional burnout and improve your well-being. And then finally, we've been starting work on advising the healthcare industry on well-being initiatives. And I'm going to share that with you because we're about to launch something that's very exciting next week with some groups that I think you'll be very supportive that we've been including. So let's talk a little bit about the awareness, because part of what I've come to learn with this deep-rooted stigma that we have around suicide, around just frankly getting mental health support, is that they make a big difference. So pretty much anyone who's asked, we have gone and spoken with. We have served on panels, Jennifer and I, across the country now, talking from everything from students, even high school and college students, all the way through physicians, practicing physicians such as yourself, medical students, nursing students, et cetera. We have 65 million reaches so far across the world in terms of how many people we have been able to touch in this conversation, having gone on the Today Show, ABC News, CNN, having written a piece for Vanity Fair. The New York Times has published a number of pieces. And then we have co-authored and authored over 7 national articles, including our first piece, which was in US News and World Report, importantly on the day that Best Hospitals in America publishes. And we published intentionally on that day because we included in that a call to action for many areas of the industry, as well as including in particular the rating agencies such as US News and World Report, to add the well-being of the workforce as a factor in determining the best hospitals in America. We've also published in the National Academy of Medicine, on CNN, the Boston Globe, the Dallas Morning News. We recently published a paper, an academic paper with some notable suicidologists on physician suicide in the Academic Medicine publication owned by the AAMC. And most recently, we published an op-ed with a legislator from Pennsylvania, Congresswoman Susan Wild, who lost her partner to suicide 2 years ago. We published in the Hill publication. So we've been on this big awareness campaign. And what I would share with you on that is early on in this work, Jennifer and I said, and we turned to each other and we said, if we can just help one person, it will have been worth it. Well, on the eve of Thanksgiving, we received an email from a physician who did not want her employer to be identified for fear of the stigma. But what she wrote to us so eloquently was that just reading the story about Lorna's career and who she was as a person gave this physician an opportunity to really do some self-reflection that she'd been ignoring for many, many years. And she got help. And she wrote us on the eve of Thanksgiving that sharing Lorna's story truly saved her life. And what I would share with you all is that even though we got our one, we're just getting started with this work. And we have now many others who have shared with us that just by talking about this started a conversation and broken down that initial barrier to having to working on the stigma and hopefully reducing suicide across the country. Another way we've done this work through our advocacy work and our awareness work is at a national and federal level with the Dr. Lorna Brien Healthcare Provider Protection Act, or the Lorna Brien Act for short. Working with U.S. Senator Tim Kaine from Virginia and a bipartisan group in both the Senate and the House. The House is led by Congresswoman Susan Wild, who I referenced a little bit ago. We have a federal law which has been introduced and and supported by over 70 healthcare organizations, which does four things, looking at making an immediate as well as a long-term impact on this issue. So number one, it invests in the future healthcare workforce, the medical students and the nursing students, and it invests $80 million to support programs for the future workforce. Number two, it provides $40 million for current hospitals and health systems to take care of their workforce. Number three, it provides funding, a $20 million national awareness and best practices campaign to share this information across the country, this critical information, and get best practices in the hands of all of those who need it. And then finally, no law is complete without a study to understand the impact both of the issue as well as the interventions. Now, even though the Lorna Brien Act is still pending action by Congress, we are so incredibly thrilled that it already has been funded in the most recent COVID relief package, the American Rescue Plan. $140 million have already been allocated to Health and Human Services, as well as the CDC for these dollars. And we need the act passed. So one thing I'm going to ask you all to do before we get off the line is to get on our website and make sure you contact your Congress people, because we've got to get this passed, because even though the money is there, it's still general budget language, and we need more specifics from the Lorna Brien Act to get this money allocated in the way we want it to be done. In addition to this federal work, as Dr. Massoud shared, we've been working and partnering at a state level with the American Medical Women's Association on the Humans Before Heroes initiative. And what I would share with you there is that that work has really just begun in terms of its effectiveness. There was a lot of really great background work that we've done with that group to try to make sure that we understood what the current state of licensure is. So we've got that done now. And I want to thank the leadership, and some of those are on this call right now, the leadership of that, Dr. Lois Swisher in particular of Pennsylvania, who's really helped lead that effort to really do that analysis. And now we've got to get the word out so that individuals understand what their state rules are. You know, tragically, my sister-in-law was incorrect about the laws in New York State. The laws in New York State do not ask questions about mental health treatment. They just don't. And so this is such an ingrained concept around licensure that it is critical that individuals, every single doctor, know their state laws. It's then going to be critical for the laws to change, but we've got to do both of those parts. And so that foundational work has been done, and we're so incredibly proud of being part of that partnership with the American Medical Women's Association. In addition to those efforts, we have raised about $300,000, which we intend to disseminate to organizations, both for research and for programs, not unlike the programs in the Dr. Lorna Breen Act. And I won't, because I'm running short on time, I won't get too much into that because we are really still just trying to raise even more funds for those programs. But I want to share with you in closing about a new program that we're launching, which is incredibly exciting. So as many of you know, the healthcare industry can be a little siloed at times. And one of the things that has been, this is obviously an issue that is similar in that way. And so as a new foundation and a foundation that's done a lot of awareness, I've been on the receiving end of a lot of people who are working on this issue individually. And so trying to bring them together is the next goal. One of my groups of partners in this journey has been an interesting group that came together this time last year to support healthcare workers. And the group includes the Harvard School of Public Health, the Thrive Global Corporation, as well as the Creative Artist Agency, which is the world's largest talent agency. Now, what were they doing in this space? They were trying to come together to ask this exact question that we've been talking about today: who's caring for the caregivers? And they raised a number of funds, which they initially allocated to PPE, which is what was needed at this time last year. But what we've decided to do with them, and they work under the banner First Responders First, we've come together with them to launch an initiative which is entitled the All-In Wellbeing First for Healthcare Initiative. And we're launching that initiative on April 21st. And this is the exciting part, is that we've pulled together the American Medical Association, the American Hospital Association, the American Nursing Association, the Schwartz Center for Compassionate Care, and a list of others who aren't formally joined yet. But we are going to be working with those groups to then build a national awareness campaign in an attempt to get every healthcare leader in this country to sign on and visibly commit to take care of their workforce. We've been talking a lot tonight about the fact that this is a mental health issue. It's also a leadership issue. This is a workplace leadership issue that needs to be recognized, and solutions need to be brought to bear. We've heard from many over the last year that the workforce does not currently feel valued. In fact, there's a recent data that suggests that only 50% of the workforce in healthcare feels valued. The workforce needs to feel valued, folks, obviously, and it needs to be able to sustain the sense of purpose and meaning in the work that is what drew you to the profession to begin with. But we need to return to that state. And so together with the AMA, the AHA, the ANA, and the Schwartz Center and others, we are going to pull together the best and brightest tools to do this, design a future together that we hope will cascade the healthcare industry. And we want everyone to join us on that journey as well. And so we're going to be asking and rolling this out after the 21st. We're going to be asking organizations who join us to publicly declare their leadership's commitment to the well-being of the workforce, and acknowledge the role of their organization in investing and in cultivating an environment where their workforce feels valued and supported. We're going to ask each organization to clearly define goals to improve the well-being of their workforce, and then utilize these tools that these collaborating partners of the AMA, AHA, ANA, and the Schwartz Center have already got published. Those tools are out there, but use those tools to help you on your journey. It's our hope that between that and the resources, the financial resources that we have through philanthropy, through the First Responders First initial philanthropy and further philanthropy, as well as the dollars from the Lorna Breen Act, that we will not only be able to help the industry evolve to the future that it so deserves, but also provide the financial tools to get there. So that's our foundation, and that's what we've been up to. really thrilled to have this conversation this evening, and apologies for going a little bit over time, but our website is drlornabreen.org. You can find out a lot more information about us and join us in our journey, and we welcome you to that.
Thank you very much, Mr. Feist. I think I can say that I speak for everyone that just listened to your presentation. That really, I hope that you'll accept our condolences for your family's loss and our appreciation for the work that you and your family have done to help ensure that no other family experiences a similar tragedy. Thank you. This brings us to the end of our formal panel presentation, and we'll have some time now for questions from our participants, for our panelists, and discussion. While folks orient themselves to the chat function, and actually I'll direct you to the Q&A button that you have at the bottom of your Zoom screen to help submit questions. I do want to also introduce Dr. Michael Weinstein, who is an acute care surgeon, joining us for the Q&A portion of the presentation. And Dr. Weinstein, thanks so much for joining us. And if you'd like to introduce yourself and say a few words, we'd appreciate it.
Dr. Winterstein pointed out, most of the time I want this type of panel or give this type of talk because I disclosed my own journey through depression and suicidal ideation several times. Published it wildly, and just like Mr. Feist was saying, the response to telling such a story is incredible. People from all over the world reach out and either thank or share their story. We're certainly had similar experiences where people say that story came just in time at the right time. I should say also that I have, along with others, have founded what's called Live Well Clinicians. The Live Well group may be familiar to some folks in Philadelphia. That was Live Well was created to provide free depression support, realizing that the current systems of care, especially the public system, has been disappointing. And we offer almost nightly support groups open to the public, and as well, most recently started a physician support group. And since everything is now virtual, both are not just confined to the Philadelphia area, but can be across the country. And I can put the link in for both of those in the chat. But we have a physician support group every Wednesday night, 7 p.m. That's where I'll be right after this.
Thank you very much. So we'll open it up now for questions from the audience. The first question I see is, do you all think that financial worries, specifically huge student loans, may have something to do with the high levels of suicide in physicians and veterinarians? Is that something that comes up in the conversations? And maybe I can direct this first question to Dr. Winterstein, given some of the interface that you've had at the college level, and others should feel free to chime in as well.
Yeah, I think certainly when we're talking about our medical students, this issue does pop up sometimes. You might see somebody who got into the field of medicine because, their parents were physicians, or they'd always been kind of pigeonholed for you're a science person, you should go into this field. And so they've kind of headed in that direction for some sense as to what this might be like. And, they go through their academic years and classroom work is all fine and good. They hit their clinical rotations and suddenly realize, I don't know that this is what I really want to do. The problem is at that stage, they're a good $200,000 in debt sometimes, and really struggle to figure out, how do I get out of that circumstance and relieve myself, if you will, of that loan debt. And there's very few other professions that they can go into if they don't finish their medical career, that would actually go off and pay off their medical student debt. So that's certainly an issue that does pop up.
I'll segue to the next question, which is, what is your personal opinion on what we need to prioritize when talking about this mental health crisis? I know there were a lot of solutions discussed, but what could be a good first step? And I think this is a great question. And after hearing your presentations, I'm sure many of us are left with a feeling, both an appreciation of the enormity of the challenges and a real desire to help. And so wondering if in answering this question, whoever responds is able to really identify perhaps something that each one of us could do, say in the next 90 days, to be helpful in this area.
I'm happy to throw one out.
That would be great, thanks.
Sure. While many of the solutions here are complicated, redesigning your operations of a hospital is an example to decrease burnout. Take some time. The cultural work here, checking in on each other, being aware and taking care of yourself, it's not hard. It doesn't cost any money. We've heard from one of the co-founders of National Physician Suicide Awareness Day talks about the double tap. It's asking the question, how are you? And then asking it again, how are you really? I'd say everyone on this call can do that with one colleague. I'll share with you, just 2 weeks ago, I was preaching that. And then about a week ago, somebody who works for me noticed that I was having a hard day, and he did that to me, and it caused me to stop. And we had a totally different conversation than we were going to have. And I think that just something as simple as that double tap can go a long way to just evolving us on this journey.
I'd like to also something we can all do is recognize the impact of stigma on blocking people's awareness and accessibility or access to supports. But one thing we can all do is recognize that we need self-care, and that that it's okay to not be okay, that these are very difficult times, and that doing something for yourself that gives you some pleasure and joy, even with all of the responsibilities to others, that you take care of yourself as well. I think that's probably step one for your own health and wellness, and to support your ability to be there for others.
Thank you. I think those are practical and really excellent suggestions. Anyone else care to ring in on this question?
We just echo that. I mean, the most important thing is to develop awareness. Without awareness, community-wide, and understanding and compassion, we can't move the needle in any direction. And so we need to have these types of conversations and discuss how do we break the stigma? How do we get enough people feeling comfortable to reach out and look for care? You know, I hear from physicians who are afraid to see a mental health provider because they're concerned that someone will see them, or they're concerned that it will be on their insurance plan. So they will go around the insurance plan, go to a distant community and get help there, or simply not get help at all, which is really disappointing and scary that our own community who provides healing is afraid to get help themselves. And you mentioned self-care. You know, it's important to get the message across that self-care is not selfish. Taking care of oneself is the best thing that we can do for ourselves and for others.
Thank you. Sticking with this theme, but perhaps pivoting somewhat and thinking about sort of systems level solutions. This next question, I'll direct initially to Dr. Shriyanka, Dr. Bowen, but others again, please feel free to chime in. Could the panelists comment on or discuss solutions for our most vulnerable colleagues, women, physicians of color, and how the stressors of the pandemic are further pushing these groups to the brink? How can systems support them as we move through and out of the crisis? System solutions, not self-care, is the question. So Dr. Shoyenka.
Thank you. I think that's an excellent question. And I think it underscores one of the narratives that has really been made prominent by the pandemic, which is the disparity in access for communities of color, which include physicians. I think it also should be mentioned that oftentimes these physicians have, in addition to the pressures we've already talked about, the additional experience of living with racism, which has also been underscored through this the events of the past year. I would say certainly the literature is pretty consistent in pointing to the fact that access and engagement and outcomes are actually improved when individuals are matched with providers of similar ethnicity and background. So I would say one system change that needs to happen for certain is increase the numbers of physicians of color, mental health clinicians of color that are being trained. And there are ways to do that. Actually, the Pennsylvania Psychiatric Society, Pennsylvania Psychiatric Leadership Council is doing some work on this right now as we speak. I think it's also important to recognize that racism is its own stressor, and be very intentional about, and will impose, in addition to just the structural barriers, additional pressures that must be acknowledged and responded to in these clinicians and physicians of color. And so that obviously, I think hospital administrators have a large role to play in addressing this.
And I'll add to that the recognition of really the multiple layers of trauma that people are experiencing, including centuries of systemic racism and the violence around us, but particularly for Black Americans, for those of Asian descent right now, the violence, and we're in the midst of the hearing, the George Floyd hearing. And so the tensions and the anxieties have to be acknowledged. Reach out needs to be there, but if we're really talking about a systemic solution, we really need to look at where systems add trauma, additional layer when people are already in distress, as opposed to mitigating those traumas. Even to the extent where folks need to go to the highest acuity services instead of having access to services more upstream, preventive approaches that occur in the schools, and very much tapping into the wisdom of communities and neighborhoods, the power that's there, engaging community leaders and clergy to be supportive, and as much as possible for folks to be able to get access to the system as early and as upstream as possible, and to bring those services to those communities and those neighbors, and really try to remove the kind of traumas that come with crisis responses and emergency room visits, et cetera. The fewer of those, the more people who are already in distress can be met with approaches that relieve or alleviate the trauma. Then you got some systems change.
I think I'll just say one last thing, and it's just piggybacking on what Dr. Bowen just said. The literature is pretty clear when there's an event like what happened in Minneapolis recently, shooting of that young man. The literature is pretty clear. Black people experience that as pain in the moment, not as a news item. And so I would say at that moment, in those moments, checking in with your Black colleagues, physicians or other staff would be, sincerely checking in on them would be a helpful gesture.
Thank you for that suggestion, and Dr. Bowen, for your responses and thoughts at the systems level. I think there is a tremendous appetite and desire to have really practical solutions, things that people can do. And you've identified one at really the systems level, at the treatment level, helping to really advance trauma-informed and other evidence-based practices, and really at the individual level, to Dr. Sharenko's last comment. And I'm, looking at the rest of the questions and reflecting on some of the themes, certainly stigma and stigma reduction has emerged as a very prominent one. And we've already heard a number of different approaches and solutions. We've heard ways in which data at a population level can help break through perhaps some of the denial associated with the enormity of the challenge. The power of a personal narrative that we have heard from Dr. Weinstein, from Mr. Feist's family, the power of disclosure, and what together, these are just some of the strategies. One of the questions here relates to whether there are other approaches that, and specifically the question is, can you speak to the stigma of the system where we all feel that there will be ramifications for our work or our careers? So with the acknowledgement that we've already talked about a number of strategies, are there additional thoughts on this topic?
I can share a few as I've looked at the layers here. So there are obviously stigma reinforcers, which is what I guess where we're trying to focus. And the state licensure issue, the credentialing and privileging process that happens in hospitals, the application for medical malpractice insurance, and the application and credentialing on commercial insurance. I think all four of those areas are places that we need to summarily change. And one of the things that we're working on as our foundation is doing that. But those are the kind of things that have got to get out of the way. But that work doesn't obviate the need to have these conversations among the peers. And I think that's the challenge that we have, because we can eliminate all those reinforcers. But if the peers and the culture within medicine doesn't acknowledge its responsibility and make the changes, then we are in a different spot. I will tell you all what's interesting working with medical students on this issue is they have a totally different expectation entering the profession about the way that their mental health will be taken care of. And I think that over time it will evolve, but I think we have to start now by having the conversations about the visioning conversations around how do we design that culture where we can support each other and we can have these open, very hard conversations without fear of retribution, because that is, I hear it every day. And some of it is, some of it's real, some of it is just perception from the environment. But until we just talk about it to a point where we make it okay, and we work through those reinforcers, those four that I just talked about, I don't know what we can do. So those are the areas that I would suggest need to happen.
I think we also have to, talk a lot about how pervasive mental health challenges are, how common it is, and for folks to recognize and be able to speak about, anxiety the same way that they can speak about asthma. that it is just, a part of the human condition. It's common. It's not something that is unusual, especially now where depression and anxiety is even higher than it normally is, that it is common. And I think if you ask, I've never, will you find someone who says they are not, they have no awareness of anybody who has a mental health challenge or a behavioral health challenge. Everybody, either for themselves, their family, a neighbor or colleague knows someone, because it's that common, it's that pervasive, and it needs to be understood in that way. And it's helpful to speak about that. And I think also, behavioral health organizations can model workplace approaches to folks who need mental health days. I mean, that's a strength. When you ask for things like that, or you seek supports, that's a strength. And that should be something that's supported and encouraged by organizations, and something behavioral health organizations should model.
Thank you. Dr. Weinstein.
Physician perspective, one other way potentially of deconstructing stigma that's been discussed is having an opt-out program, for instance, for medical students and residents. And I'd love to hear Dr. Winterstein's thoughts about this. It may be resource intense, but rather than having counseling services simply available, everyone is scheduled at least for a yearly visit, so they have access and they understand access, and that it's destigmatized. This is something we all do for residents, students, and maybe even attending staff.
Yeah, I think, it's interesting because not too many years ago, I approached some folks even within our own institution to have a discussion about, every student who comes on board has to show up in occupational health to present their vaccine documentation, a whole host of other things like that. Why would we not do a mental health check on everybody when they come in, not to stigmatize the environment and say, listen, you're going to be stressed out. We just want to make sure you're going to be like where you are to start with, but rather to be that initial point of contact to say, how are we doing right now? We're doing okay right now. Well, I just want to introduce myself, and here's how you can get in touch with me later, because we know people often don't make the call because they're scared to death of somebody else is going to answer the phone, and who are they and what might they do? And medical students are notorious for, I'm not going to seek help because you're going to tell the dean. And that's going to create a problem on my clinical rotations, or something's going to happen as a result of that. And there's a lot of fear about who's going to know what, back to the original question about ramifications and so forth. Like, the students experience that too. On the faculty level, it comes out in lots of different ways, particularly during this pandemic. I was talking to an anesthesiologist from one of the city hospitals recently who was talking about, since COVID started, there's no days off. No one gets days off. You're just working extra days, and you can't function without days off. There's people leaving that field, that specialty, because they don't get time off. And the fear is, if I ask for a mental health day or need to go out on leave for something, that they need people and they're going to be upset with me. And that's going to cause a dismissal or something like that. And there's going to be some ramifications for that. So it's a real challenge, but I wish there was a simple answer to it. But I think checking in with people, all the things we've talked about on this panel in the last half an hour or so here, I think are all relevant to this issue too.
That sounds like it really all rolls into this theme of opportunities to normalize mental health, and the recognition that it is a part of our world. It disproportionately impacts healthcare workers, and the more we can help to normalize that concept as early as possible in training or in any contact within the field, the greater the likelihood that people will seek care earlier, that the feelings and barriers related to stigma and fears of ramifications will be lowered.
And this was discussed quite a bit by one of the panelists tonight, but the importance of peer-to-peer is critical. People with lived experience that resonates with you, that you trust, it can be incredibly important.
Yes, thank you for raising that, Dr. Bowen. Dr. Massoud unfortunately was called away unexpectedly, but of course, her presentation, her work related to the helpline really speaks directly to that point about the power of somebody with a shared or similar experience to be able to relate. We seek that out, and yet, like healthcare in general tends to be a profession that has expectations around autonomy and values, the ability to be capable of withstanding extraordinary amounts of stress, sleep deprivation, lousy hospital food, the list goes on. And our ability to recognize that that there are people out there that have gone through similar experiences that we can talk to. Again, an effective means of lowering that threshold. We're approaching the end of our time, and I'm just going to do a quick scan here to see if we had any final questions before handing it back to Dr. Mamin, who will close us out. One other question that I saw actually relates directly to this content around stressors and in particular about overworking. And the question was, do you think the current model for, well, it's two questions together, both I think are similar. First, do you think that hospital understaffing is a contributing factor to the increase in physician suicide rate? And I think we've heard that in particular during COVID, this idea of no time off, no space, and by extension, inadequate staffing clearly appears to be contributing to staffing stress, excuse me. The other question is, do you think the current model of for-profit hospitals creates an environment which breeds mental health issues in staff? I think we can, at the root of the question is, are there aspects of healthcare, whether for-profit, non-for-profit, government, wherever, are there ways in which we are delivering care that in fact undermines the health of the healthcare workers themselves? Somebody care to weigh in on that?
I can quickly just note that I was 2 minutes late for joining before this because I was on the phone with a healthcare professional at the University of Virginia who was said, it's a nonprofit. Our push for productivity is breaking. I'm burnt out and I'm considering leaving the profession. So I would not tag it to for-profit hospitals. I would tag it to the fact that the financial stressors of and the reimbursement system and the compensation design for many, which is an eat what you treat model, and the pressures now are making this issue on an beyond exhausted workforce even worse.
I think simply the answers are probably to both of the questions that were out there, and we simply don't have the data to say definitively one way or the other. But telehealth has created an environment where we can see patients whenever we want, right? So perfectly fine to see somebody at 11 o'clock at night. No, it's not. But this is sort of the environment that we're living in now, that everybody's almost on demand whenever they're needed, and that's not very helpful, I think, for people managing their own well-being.
Yes, the growing demands of the on-demand world. Dr. Weinstein, did you want to bring in a final thought here, and then I'll hand it back to Dr. Mamin.
I feel like it's yes and yes. Just the feeling of being overstaffed and the feeling as though you're not delivering the best care possible, I think is a major contributor. And much of this does come from my own perspective. And then the commodification of medicine, we call it now an industry, and it's a shame. We are RVU machines, and productivity is the bottom line, and that is pervasive. Doesn't matter whether it's for profit or not for profit, they're still for profit. And so that's a major contributor and a major system change that is going to take quite a long time, if at all, to be repaired.
Yes. Well, Mr. Price, referenced some of the evolving expectations of med students coming in and perhaps the demands that they are placing on systems and on facilities, hopefully to get them to change their offerings and their approach. And perhaps one of the takeaways for all of us that have participated today is that we have a role to play in reestablishing or establishing anew what the expectations are of the systems in which we work, about being more attentive and more aware of the mental health needs of the healthcare workforce. And so that we can add to the list perhaps of takeaways from this evening's outstanding presentations, that we do have this power within us to help establish a new normal around stigma reduction, around awareness of the impact of mental health challenges, of stress, of substance use disorders, of all of the things that we know contribute to the rising and elevated risk of suicide among our ranks. Please join me in thanking our wonderful panel for taking time today, speaking from their experiences, their expertise. This has been really an extraordinary evening, timely, relevant, and tremendously valuable. So thank you. And with that, I will turn it to Dr. Priya Maman.
Hello, everyone. Good evening, and thank you so much, especially to our panelists, our tremendous moderator, Dr. Herford, and all of you in the audience who's joined us for this incredible discussion and laying out of the data that we're all dealing with. I think, as our panelists have shown, this is not just a unidimensional issue. It is very large, very deep, but as we have all seen, and one of my great mentors always taught me, power belongs to the problem solvers. And so we see so much tremendous hope from efforts from groups like the Michael OBrien Heroes Foundation, the Feist family, Dr. Mona Massoud, who really capitalize on need and went to work. And that is really what the core of all of us as a workforce has done in terms of both medicine and higher education, of just getting to work. At times, we need other people to remind us that we are just as important. And it's not a normal way or usual way for us to think. So I call on everyone in the audience, I call on all of the leaders around us to really take stock of where we are. What Mr. Feist, his other hat, as he sort of mentioned, is being the CEO of a physician's practice, a very large physician's practice. And so he has shown how you really can start to implement these systemic changes in just the way we work and in the way that our systems are built. I will say certainly one of the views that I have as an emergency physician and as a public health expert is where the upstream issues land full force on us on the front line, on our patients who are doing their best to navigate the system, on our students who are doing their best to understand how to take steps forward. And so it really is both an upstream issue as well as an acute issue that we need to face right now. I think we've also seen that we are at a tremendous inflection point in our country, in our region, in our community. And unfortunately, I will say the worlds of medicine, the worlds of higher education tend to be very large incumbent institutions that are very slow to change. But we can take lessons from the business world. We can take lessons from the problem solvers in our midst to say, change will begin with a single step. And efficiency is really about keeping your workforce well and keeping them cared for and making them feel safe so that they can do their work in the best possible environment. So with that, I thank you all. Again, it has been a tremendous evening. Our panelists have been phenomenal in the information that they've shared. Dr. Mona Massoud, as in typical of all of our lives this year, had to be called away for an emergent issue, and I know she's sad to miss out on this part, but we thank her for her time and effort, and most especially for her efforts in really taking a step to address the needs of physicians especially. And to everyone in the audience, I thank you for staying with us this long. This has been an incredible conversation, and I hope to continue it on many levels in days, weeks, months, years to come. Thank you so much.
Thank you all. Have a good night and be well.